Petang, saya Hanif. I will I will be presenting CME regarding diastology. So, okay lah, since dah 4 PM and everyone nak balik, I'll try to keep it as interesting as I can. Bila-bila masa, if you have any questions, you want to interrupt, just tanya saja. Dr. Ben, if you want to add anything, please, have a chance. Okay, so, introduction. So, everyone is usually preoccupied with the LV contraction during systolic, and we forget that the relaxation of the LV is also just as important for the pumping mechanism of the heart. So in 1980, Yuzo Hirota, he did a study which uncovered that the relaxation, LV relaxation abnormality is one of the earliest manifestations of heart failure. So this was in 1980, and this study was conducted by left heart catheter, not by echo. So they noticed this in 1980 by left heart catheterization. Okay? And then fast forward 20 years later, Fritzenberg and his colleague did a study which noted that the tau is the myocardium relaxation index. So the higher the tau, the better. So this guy noticed that the tau is inversely proportionate to the E prime from the echo TDI. So that's how he was able to assess the relaxation, the LV relaxation by echo. So this was in 2000. So because of this, we are now able to study the diastology or the LV relaxation by echo. Okay, the physiology is very important because if you understand the physiology, you won't need to memorize too many things. Tapi it's difficult. I myself pun still trying to understand it. Tapi try to be patient and don't give up lah. So diastole is the interval between AV closure and MV closure. So basically from the end systole to the end diastole. You can divide the diastole into 4 phases: isovolemic relaxation, early rapid diastolic filling, diastasis, and late diastolic filling caused by atrial contraction. Okay. While I explain, I want you guys to focus on the picture of the heart below. So, okay, where's my computer? Okay, so this is the isovolemic relaxation. This is the first phase of the diastolic phase. Okay, so the isovolemic relaxation phase, it begins when the AV closes and it ends when the mitral closes. So during this period, the LV pressure drops drastically. So when it drops drastically until the mitral valve opens. And when the mitral valve opens, this will initiate the early rapid filling. So you see during the isovolemic relaxation, the heart within the L8 is still there. Dia tak pergi mana-mana. That's why you don't see any wave. Dia nak macam mana dia nak pergi, the MV is still closed. So dia akan stay in the L8. Okay? So the drop in LV pressure will initiate the opening of the MV, which triggers the early rapid filling. This is a passive process, okay, and it's actually responsible for most of the movement from the LA to the LV. Sorry, ada komplain suara nak cukup kuat. Yep. Can anyone hear me? Rajan, okay Rajan?
It's not quite. So mic about.
Okay, can anyone hear me? Testing.
See that your
Oh yeah. Boleh dengar? Okay. Testing. Testing. Sorry, sekejap This is the point.
Hello, hello. Testing. Clear tak?
Clear.
Okay. Alright. Sorry, iklan sekejap. Okay. The isobalamic realization, it begins when the AV closes and it ends when the mitral valve opens. During this period, the LV pressure drops. It drops until the mitral valve opens, and when it opens, it triggers the second phase, which is the early rapid filling. So during this phase, the blood from the LA will passively move into LV. So the blood from the LA with the blood from the LA with the high pressure will go to the LV with the lower pressure. Okay. So as the blood moves from the LA to the LV, from the high pressure to the lower pressure, the pressure between the LA and the LV will equalize. So when the pressure equalizes, there will be little movement from the LA to the LV, and that's why you get the phase between the E and the A wave. Okay? So during the diastasis, the pressure between the LA and the LV is almost equal, that there is no movement, which is why you don't see any wave between the E and the A wave. Okay? So the diastasis phase ends when the atrial contracts, and which then forces the blood from the LA to the LV, which is responsible for the A wave. So the E wave we always see on echo, it resembles the early rapid filling. So any problem with that, you will find an abnormal E wave. Okay? So E wave is the passive filling of the LV from the LA. Whereas the A wave is the contraction, so it's not passive, it's forcefully pushing the blood from the LA to the LV. Okay? And the A wave, or the atrial contraction phase, will end when the mitral valve closes, which starts at the beginning of systole. Sekarang ni semua okay ya? So yang ni sangat penting for you to understand the later thing. So okay, so isobalamic realization, blood doesn't move. Early rapid filling, blood passively move from the LA to the LV. Diastasis, the pressure is equal, so there's no movement of blood. And then atrial contraction, the blood is forcefully pushed from the LA to the LV. Okay, so you have your E wave and you have your A wave. And gambar kat bawah ni is quite helpful. Okay, alright. So the relation of the phases to the ECG is also quite important. So just remember that the diastole begins at the end of the T wave and finishes just before the R wave. Okay, clinical management, I won't go too much. Basically, just know ProBNP is helpful. Patient can have like symptoms of reduced effort tolerance or even overload symptoms, kan? So kadang-kadang when you get echo request to rule out for diastology assessment, tak salah lah if you want to ask the doctor how's the ProBNP, kan? Alright. And these are the causes of heart failure symptoms we have. Susah nak hafal everything, but just remember when you get heart failure symptoms you have, the investigation, it doesn't stop there. You still need to ask yourself, why is this patient having heart failure symptoms? This is the management according to the ESC 2023. Okay, so you can see SGLT2 is highly emphasized. Okay, the diagnostic criteria. The ASCP, the American Society of Echocardiogram, just released a guideline, just published a guideline last month, July 2025. So this is the new guideline. It looks nice, color lawa, tapi actually I prefer the old one. Okay, the old one looks more easy to understand. Okay. Okay. Referring to the ASC guideline 2016, there's two algorithms. one algorithm if the myocardium is normal, and the first algorithm is for a normal myocardium, whereas the second algorithm is we use when the myocardium is diseased. Tapi of course, for patient with the normal myocardium, we use the first algorithm, and once we convince that the patient have diastolic dysfunction, we move on to the second algorithm. So remember, kalau normal myocardium, algorithm 1. Kalau memang kalau ada diastolic dysfunction, you move on to algorithm 2. Tapi when the myocardium is already diseased, you terus go to the algorithm, the second algorithm. Tak payah, don't waste your time with the first algorithm. Okay? Boleh tak semua tangkap gambar ni, sebab later there's going to be some examples and I want you guys to derive lah. Memang this one tu lah, I pun susah nampak juga. So you guys tangkap gambar, and then later there's going to be some examples and I want you guys to tell me lah which okay, sorry. So this one. So you see the first algorithm, I think it's quite simple. There's 4 criteria. Kalau one is positive, normal. 1 or no or 0 positive is normal diastolic dysfunction. Kalau 3 or more is diastolic dysfunction. You move on to your second algorithm. Tapi kalau 2, then indeterminate. Susah, tak boleh sembang lagi lah. Okay. Jadi pun tangkap gambar juga, okay? Later I'm going to be asking also lah. So, okay. Alright, for the ASC, yeah. So for same guideline, the 2016 one, tapi this is the second algorithm. So we use this if the myocardium is diseased or if the first algorithm is positive. Okay? So you can see first you need to know the EA ratio, and only from the EA ratio you will know where to head. If the EA ratio is less than 0.8 and the velocity is 50 less than 50 centimeter per second, then you know this is normal grade 1 diastolic dysfunction lah. Okay? Tapi kena ingat, usually grade 1 diastolic dysfunction, the patient is usually asymptomatic. So when the patient is symptomatic, you need to ask yourself even more so. You need to consider maybe coronary disease. So you can do a diastolic assessment. Whereas if the E over A ratio, is more than 2, then you don't need to go through all the algorithms because you know that this patient has grade 3 diastolic dysfunction. Okay. Kalau perasan, the parameters mentioned in both of these algorithms is actually more or less the same. E over E prime, sector E, lateral E, velocity, lagi, sama juga dengan sini. So, kenapa these parameters are important is because this parameter resembles, signifies the LA pressure. Okay. Dalam in heart failure preserved EF, the villain, orang jahat, is actually the stiffness of the LV. So because of the stiffness of the LV, it creates a resistance for the blood from the LA to go to the LV. So the pressure in the LA will build up. Okay? And once the pressure in the LA will build up, this will cause stress on the pulmonary vasculature, the pulmonary vein, pulmonary artery, and this is why this patient, the EF might be preserved. Tapi because of the stiff LV, because of the increased LA pressure, the patient will have symptoms of heart failure. They can even have worse symptoms of heart failure as compared to those with EF of 30%, 40%. Okay, very bad. So ni dah tangkap gambar dah, okay? Alright. Okay. Kalau perasankan kat tengah-tengah ni, there is also an indeterminate punya section juga. Alright. So when I mention disease myocardium, this is what I mean. The EF is down.
Sorry bro, the picture in the live dia tak update tau.
Oh really? So you guys cannot see
Yang phone punya.
Tidak. So yeah, bathroom break.
Yes, biasa ni.
Dari awal tadi.
Dari awal tadi. Macam mana? Oh, tak apalah, I buat macam ni lah.
No. Share the screen on the full screen.
Yeah. Yeah.
Share the
Now okay
screen.
lah.
Full screen.
Okay, boss.
Now okay, boss.
Now okay. Full screen.
Keluar.
Dah keluar dah.
Nampak?
Oh,
Alright.
dahsyat bang.
Excellent.
Bukan totally.
Okay lah, I think okay. So just to recap penting ni. So this is the first algorithm from the 2016 ASC guideline. We use this when the myocardium is normal. When the myocardium is not normal, when the myocardium is diseased, we go to the second algorithm, which is this one. Alright? So this is what I mean by disease LV myocardium. The EF is down, RWMA, or there's LVH more than 1.3 cm. Okay. So tadi perasan kan, there's a section for indeterminate. Indeterminate basically means we cannot say whether there is or there isn't LV diastolic dysfunction. So these are additional parameters which we can use to ascertain that. Because later I'll be telling there are some cases where you cannot use the E over A ratio. Macam tu lah. Untuk patient with AF, there's no atrial contraction, so there's no A wave. So in those cases you tak boleh guna the algorithm. So you have to use these extra parameters. Okay. The one on the left I'm more familiar with, tapi the one on the right I'm not so familiar with, tapi it's mentioned in the ASC guideline 2025. Okay, so the first parameter, okay. This one, cuba try to faham. So basically the left one, this is the normal E and A wave. So E is the early rapid filling, and then there's the diastasis, and then there's the atrial contraction. Okay, so this is how it's supposed to do. The E is supposed to be higher than the A wave. Okay, because most of the blood movement occurs during the passive feed, not because of contraction. Okay. Okay, so when this is impaired relaxation, meaning the myocardium, the LV myocardium, it takes a while for it to relax. So when it takes longer to relax, the deceleration time, which is the time from the top of the E wave, the peak of the E wave to the baseline, dia jadi lagi lama lah. So since it relaxes slower, the deceleration time will become longer. And if it does slower, the velocity also will become lower. So that's why the E wave is shorter than the A wave. Okay? And because there's less movement of blood in the E wave, dia banyak pass over dekat the A wave lah during the atrial contraction. So that's why when you see the E wave is less than the A wave, then you should suspect that this patient will have impaired relaxation. Okay, impaired relaxation is the great one. This doesn't necessarily mean that the patient has increased adequation. They can have this. Usually they don't, because it's slow relaxation, impaired relaxation. Okay, so I'll skip to the third one because it's more easier to explain. So restriction is basically when the LV is stiff, keras. So you need a good relaxation. You tak boleh laju sangat, tak boleh slow sangat. Slow sangat you get the grade 1 lah. Tapi kalau laju sangat it's actually more dangerous. Okay, because it relaxes too fast, so it doesn't allow time it doesn't allow movement of blood from the LA to the LV. Sebab laju sangat. You have to do it slowly. Baru you get more blood from the LA to the LV. So when this happens, see, it does it very fast. So because it does it very fast, okay, firstly, the IVRT, which is the isovolumic relaxation time. Okay, tadi the isovolumic relaxation time is usually longer. Okay, because the pressure from the LV, kan tadi I mentioned, the IVR is the time from the pressure will drop, from the LV pressure will drop. So if it drops slower, the IVRT akan take longer lah, akan jadi lagi panjang. Tapi in the restriction one, in the grade 3 pula, the relaxation becomes very fast because it's stiff. So when it's stiff, the compliance kurang. When the compliance is kurang, it becomes very fast. And when it's fast, it's not good. You tak boleh fast sangat, tak boleh lari sangat. Fast is actually even more hurtful than the slow one. Tapi because of this, because the pressure drops very quickly, your IVRT becomes slower. Semua okay? Susah sikit nak faham, tapi itulah. If you faham this part lah, the next part will become easier lah. Okay? Kalau nak tanya apa-apa, can just ask me, okay? Because it happens so fast, the E wave laju lah, kan? But we are talking about velocity. So when there's less time for the blood from the LA to go to the LV, it has to go very fast. And when it becomes very fast, the E wave will become very tall. Okay, so that's why you see the EA ratio is usually very high in the second algorithm tadi kan. Okay, so sama juga the IVRT becomes kurang because the LV pressure drops very fast, and the deceleration time also shortens. Okay, the normal values are here lah. Okay, tapi nampak, okay, the second one is quite confusing, so because it looks almost the same. We call it pseudo normal lah. But if you use a tissue Doppler, you look at the E wave when you do a tissue Doppler. This is why the TBI is very important. Okay, kadang-kadang you see you see the EA wave, oh nampak sama, okay lah, super. Tapi this patient have very bad heart failure symptom. But when you do the TBI, you actually see the E wave become smaller and smaller. Okay, so you can see the E wave is the smallest during in the grade 3 diastolic dysfunction. Okay. So far okay Alright. Okay, saya rasa lah. Okay, saya takut tak cukup masa. So this one I'll go quite fast lah. So okay, this is how you assess the transmitral flow. Okay. So this is the E wave. This is the A wave. So the deceleration time is from the top here to here. Okay. The IPR is actually from here to here. So we get this view from 4-chamber view, and make sure you make your Doppler parallel to the direction of the tree, and make sure you point your cursor right at the tip of the micrograph. So ini gambar. So you can see lah, boleh nampak semua. So 4 chamber, first color first, and then baru you pasang your house rule. Okay, and you put it right at the tip of the LED. Okay, try to make it as perpendicular as you can, because that's the best measurement for the for the velocity. Okay, ini sama juga lah tadi I explain. Okay, the TBI pun more or less the same lah. So I skip this part a bit fast, takut tak sempat pula lah. So you see from the TBI, this is the E wave, this is the A wave, and this is the S wave lah. This is the systolic phase. So alright, okay, in this next one, yeah. So this is where you point your cursor. Okay, right at the septal microannulus. And lateral kat sini. Okay. Like I said, try to make it perpendicular. Try to cover as much of the LV Okay, your TR velocity, I think everyone is quite familiar lah. Routine ni memang kita akan buat. So okay lah. Oh, okay. Why the TR velocity is important in diastolic dysfunction? This is because when the LA pressure is high, it exerts pressure in the pulmonary vasculature. So when the pulmonary vessels, the pressure is high, it will put pressure onto the right side, so onto the tricuspid valve eventually. So that's how you see the vegetation. So very bad one, you will see that you will see the quite significant TR. Okay, so yeah, so you do this, and then you put continuous wave Doppler, and then you measure it. Make sure you don't measure the tricuspid closing. Okay, Lavi sama juga. Like I said, all these parameters is trying to assess whether the LA pressure is high or not. So the left atrial volume index will be high. Will be high if there's significant airway pressure. Ialah pressure, so dia akan besar lah. So this is why the LAVI is also one of the criteria for LV diastolic dysfunction. So ni sama juga lah, Simpson method, Byplay. Okay, alright. So this is the normal. This is the pulmonary Doppler. This is the pulmonary vein flow. So the one on the left here, okay, the one on the left here, this is the normal S in the. So kadang-kadang we are not sure, especially during theory kan, which vessel is this kan. So you put a Doppler and if you see this, then you know. Okay lah, this is the pulmonary vein. Okay. So the one on the left is the normal. Is how it's supposed to be done. Okay. Sometimes in the dogs, the S wave can be a bit higher than the V wave. So that's why one of the criteria they also extend is the SD ratio. Okay, below is actually the normal one. The last one is the grade 3 diastolic dysfunction. This one is I tak ada marker. This one is a grade 1. So one is the SD ratio, which is important in terms of pulmonary vein flow. The other one is the AR duration. Okay, so AR resembles the back flow of blood from the left atrium into the pulmonary vein. So the higher the pressure of the LA, the more blood will move from the LA to the pulmonary vein during atrial contraction. Okay, so the worst it is, the higher the velocity will be, the taller it will be, and also the longer it will be. Okay? So the longer and the taller it is, this signifies that the LA pressure is high, and this is also one of the parameters you can use when the first 4 criteria is not as helpful as you thought. So these are the extra parameters we use when the initial 4 parameters tak boleh digunakan. There are some cases the 4 parameters tak boleh digunakan. Okay, like patient with AF tak ada A wave, patient with MR, patient with MS, those are quite complicated. Okay. Alright. So apa ni? Sama juga lah. Okay. Sama juga as this wave dengan AR. Okay. So the AR is quite important. So when you minus this number, when the duration of the AR, when you subtract it to the duration of the A wave in your mitral valve inflow, yang A wave tadi I mentioned. So when you tolak this AR to the A wave duration, if the number is more than 30, then you know that this is a sign of a high airway pressure. This is one of the parameters for early diastolic dysfunction. The other one is Valsalva. Okay, you ask the patient to Valsalva, and after 2 you see the EA ratio. Okay, so if the A wave increases during Valsalva, then this is also one of the supporting parameters for LV diastolic dysfunction. Okay, I tried my very best to find cases from my 1 month in clinic, tapi susah nak jumpa lah. Okay, so the next example is actually from Dr. Aslan Roslan punya videos lah. Okay, I think it's very good. Okay, the first case, 39 years old male, no comorbid, chest is comfort, 1 month, echo, semua okay. Which algorithm you guys use?
1.
Okay. Ni nombor dah ada dah. Mana yang tak normal? Ada nombor tak? Sorry, ada tak yang tak normal?
Lavi.
Kan? Lavi, yes. Okay, Lavi. Alright. So, okay. Alamak, tu bagi tak capai. Okay, so kalau Lavi, kalau Lavi tak ada, yang tak normal, so LV diastolic dysfunction or not?
No.
Okay lah. Okay lah, to practice lah. Alright. Okay, sebab dia normal, so we use the first algorithm. Only one positive because normal diastolic dysfunction. Okay, second patient, 27 years old, male, marathon runner, asymptomatic, buat echo. Kenapa buat echo lah? Itulah, patient VIP kot kan. Okay, so buat echo, initial echo okay. and then buat diastolic assessment. Macam mana? Mana yang okay, first sekali, okay, ignore the EA ratio. Okay, ni okay tak? The 1, 2, 3, 4, mana yang tak okay? Boleh tengok font tadi kan, tadi tak ada gambar kan? Okay. Nah, hafal memang susah pun. Ada tak yang tak normal kat dalam sini? Okay, ni tengok the lagi lah. Okay, ingat this number? Nak tak ada gambar ke? Semua okey kan? Tak gambar, tak gambar. Alright, so okay So okay, mana yang tak normal? Okay, ni lah lagi lah. Okay, tapi EA dia 2.3 kan? Macam pelik kan? High kan? So patient ni apa? Epidiastolic dysfunction ke tak? Okay, dia tak. Okay, sebab initially dia lagi saja yang positif kan. So patient with normal heart, kita first algorithm dulu. Kalau first algorithm cakap negatif, kita tak payah go to the second algorithm.
Umur dia berapa tadi?
23. Kena ingat dia sorry. Okay, one thing to bear in mind, this patient is an athlete. So athlete, it's not abnormal for the chambers to be a bit dilated. And the EA ratio is high because the heart is very efficient. So when the heart is very efficient, during the E wave, the blood, the LV sucks the blood from the LA very fast. Okay, sebab tu dia marathon, sebab dia marathon runner, sebab dia very athletic kan. So the heart is very efficient, can suck the blood from the LA to the LV kan, cepat. So that's why it's because cepat, that's why the E wave is very high. And when you calculate the E over A, it will be more than 2 lah kan. Tapi actually patient is very athletic. Okay?
Yang patient also ni tak dapat over A lebih dari 2 nama ni tak dapat.
Yes.
Yang patient.
Yes, very young patient yang fit semua kan. Betul? So alright. Okay, so the lesson learned is that kita fokus on algorithm 1. Tak payah teruskan algorithm 2. Kalau kita teruskan algorithm 2, kita dah fikir patient ni apa grade 3 LV diastolic dysfunction. Kan? Okay, case number 3, 67 years old, male, DM hypertension, overload symptoms for 4 months, pro-BNP raised. Echo initially semua okay, EF is no RWA, normal IVS. Lepas tu kita buat macam ni. Okay, first kali, mana yang tak normal? Forget about the number 5 tu nanti kita fikir. Just the first 4 one, mana yang tak normal? Senang. Itulah, I pun kena tengok the marker juga. I pun susah nak ingat. My wife punya nama pun I subscribe lah. Okay? Alright. So you see, the E over E prime dah tak normal. The septal E is low, the lateral E is low, the loud E pun dah raised kan. So actually, 1, 2, 3 dah tak normal dah. So this patient already evident. Kalau ikut the first, this one we use the first algorithm. Okay, so the first algorithm dah cakap LV diastolic dysfunction. So the next question we have to ask ourselves is what type? Grade 1, or grade 3, or grade 2. Okay, ni pun dah tahu kan. So tadi kan cakap 3 kan. So tadi the EA ratio is 1.74. So we use the middle punya algorithm. Okay, so tadi 3 criteria is positive. So we go here lah. So the patient have grade 2, ni lah increase, the patient have increased LA pressure grade 2. That's why I said, increased LA pressure is memang is the bad guy in LV diastolic dysfunction. This is why all our assessment is actually we want to see whether the LA pressure is high or not. So this patient memang ada grade 3 diastolic dysfunction. Okay, so unless we assess properly, kita takkan tahu dia ada heart failure preserved. Number 4, 40 years old, male underlying hypertrophic cardiomyopathy. presented with essentially this is 1 1, EF kita no RWA tapi IBS dia 1.5 cm. So this one algorithm 1 or algorithm 2? Siapa rasa tu? Okay. Kalau disease every myocardium, kalau the myocardium tak normal, macam kan tadi ada 3 kriteria kan, RWA, EF, IBS more than 1.2 cm. Kalau ada isu with any of those, terus go to algorithm 1. Algorithm 1 is only for orang yang the heart, the myocardium is fairly normal, right? Okay. So you terus okay, ni dia dah beritahu dah. The EA is 1.9, TR tak dapat, LAVI is 31, and then the E over E prime point is 9 point. Kan? Okay. So sini ada tak yang tak normal? Tak ada kan? So basically dia dah kata dah the EA is 1.29. So kita follow the middle one lah. So when we follow the middle one, tengok all the other parameters are negative. Kan, the E over E prime, the LAVI, kan, is negative. So kita dah ada 2 of 3 negative. So this patient actually have grade 1 diastolic dysfunction. Okay. So kalau patient is symptomatic, then we have to consider diastolic stress testing. Okay. Because grade 1 are usually asymptomatic. Because the grade 1 usually the LA pressure won't be high. So you won't have the sequelae of the heart failure prism you have. You won't have all the reduced effort tolerance, the overload semua. Okay, number 5. 20 years old male, hypertrophic cardiomyopathy, SOB, presented with SOB, PCH for 3 days. Echo the F 30% and IBS raised because of the PCM. Okay, firstly, which algorithm? 1 or 2? 2. So okay. So which one is tak normal? LAVI normal tak? Vmax, TR Vmax normal tak? Average E over E prime normal tak? So banyak tak normal. So okay. So tadi they wrote here the EA ratio is 1.3. So kita ikut yang jalan yang tengah. So tadi semua negatif, tadi semua positif, right? 3 positif. So kita pergilah dekat the ni. 3 of 3 positive. So this patient memang ada grade 2 diastolic dysfunction. Number 6, 70-year-old lady with hypereosinophilic syndrome. Datang with reduced effort tolerance for 3 months. Then poor EF, echo poor EF and normal IBS. Okay, this is the first echo, the doctor of the MV inflow. So this one perlu ikut number 1, which algorithm do we use? Number 1 or number 2? Number 1 or number 2? Number 2. So kalau number 2, kita perlu tak tahu the other parameters. Ada tak parameter kat sini yang terus beritahu kita that this patient is grade 3 LV grade 3 LV diastolic dysfunction? Ni lah the EA. Tengok dia EA. Kan more than 2 kan? Kan tadi ada mention, kalau so this one the myocardium memang tak normal, so you go to the second algorithm, and then the EA ratio memang dah more than 2. So you dah tahu, you don't need to check all your E prime, TR velocity, LAVI semua tak payah. You already know that this guy memang dia ada increase left atrial pressure, signifying grade 3 diastolic dysfunction. Okay. Alright, nice. Okay, yeah, understood. Okay, number 7. 60 years old male, ischemic dilated cardiomyopathy, present with reduced effort tolerance for 3 months, echo, poor EF and functional MR. Okay. So, okay, the EA, okay, this one, the EA ratio is more than, okay, firstly, which algorithm do we use? Number 1 or number 2? Number 2 lah, EF is poor. Okay, so when you go to number 2, you terus dah tahu dah, this guy have grade 3 LV diastolic dysfunction because the EA ratio dah more than 2.16. So tak payah nak go through all the hassle, okay? Alright. Okay, it's sebenarnya it's not just grade 1, grade 2, grade 3 diastolic dysfunction. There's also a few other groups that we should be aware of. So there's fuse increased LA and fuse normal LA. So fuse is you cannot tell the E and A ratio apart. Okay? So that happens when there's no atrial contraction. So there's no P wave. And that usually means AF lah, kan? So in AF, you just want to know whether there's increased LA pressure or whether there's normal LA pressure. And patient with mitral disease, kan, the Doppler will be very different. Sorry, the Doppler will be quite different, not very different, will be quite different. So it's very difficult to look at your E prime semua, kan. So when the patient has AF, according to the ASE, we can use this algorithm. Kena ingat, when patient has AF, the LAVI is not reliable. Sebab patient with AF, kalau dia tak ada high LA pressure, the LAVI will be raised. Okay? So the LAVI doesn't signify the high LA pressure. Okay? And the EA will be fused, but there's no atrial contraction. So you can use this algorithm to help you decide whether this patient have elevated LA pressure or normal LA pressure. Okay? Kalau patient ada AF. Kalau patient ada mitral annular calcification or MR, MS, kan, kena ingat LAVI, E over A, E over E prime and E memang tak boleh guna. So you will depend, first you look at your EA ratio, memang it's not reliable, and then you look at your IBRT, your isovolumic realization time. Okay. So these are the other parameters which are helpful for patients with other comorbids, the ones that are not so reliable. Kalau perasan in the ASE algorithm first, they dah mention at the top right which kind of patient you cannot use the algorithm. So those are the ones penting you know that these are the parameters you use for those kind of patients. You tak boleh guna the biasa punya algorithm. Okay. Alright. So itu saja. Does anyone have any question? Sorry ya, before 5 o'clock saya tahu memang it's a bit hard to concentrate. Tapi I promise I will finish before 5. Ada soalan tak?